paper from Australia. Dr. Sivabaskari Pasupathy will address us on the early use of N-acetylcysteine with glycerin nitrate in ST myocardial infarction patients undergoing primary PCI.
Thank you. So the N-acetylcysteine in acute myocardial infarction trial, or the NACIAM trial, investigates an adjunctive therapy for the PCI patients undergoing, STEMI patients undergoing PCI. I have nothing to disclose. So the background for this trial is N-acetylcysteine, or NAC, is a sulfhydryl donor with reactive oxygen species scavenging properties. It also inhibits NADPH oxidase. These properties could potentially reduce the oxidative stress and consequently minimize the reperfusion injury. Furthermore, NAC also potentiates the effects of GTN, facilitating the vasodilatation, inhibits platelet aggregation, and inhibits inflammation. These combined effects of NAC and GTN has the potential to reduce infarct size. So the purpose of this trial is to assess the efficacy of adding high-dose intravenous N-acetylcysteine to low-dose intravenous GTN in acute STEMI patients undergoing PCI. It's a randomized, double-blind, placebo-controlled, multi-center trial, and eligible STEMI patients were randomized to either intravenous N-acetylcysteine or comparable placebo with the background GTN at a lower dose of 2.5 microgram per minute. The regimen was continued for 48 hours with the NAC administered at a higher loading dose at the first hour. Early MRI was performed at about day 5, and the primary endpoint of this study is the myocardial infarct size determined on cardiac MRI. A secondary endpoint of this study is the myocardial salvage, also determined on the early cardiac MRI. So in regards to the results, about 75 patients underwent early cardiac MRI, and 38 were randomized to placebo, and 37 were randomized to NAC. The key finding from this study is the absolute reduction of 5.5% associated with the N-acetylcysteine treatment, despite the no differences in area at risk. Furthermore, this consequently increased the myocardial salvage substantially with the NAC treatment. The beneficial effects of NAC treatment is more prominent with shorter duration of ischemia. In this plot of myocardial salvage against total ischemic time, as you can see here, the effects of N-acetylcysteine compared with placebo is more marked with shorter duration of ischemia. So in conclusion, in STEMI patients undergoing primary PCI, adding intravenous N-acetylcysteine to intravenous GTN reduces infarct size, increases myocardial salvage, and has larger effect with shorter duration of ischemia. Thank you.
Great. Thank you. This is very interesting paper. I wonder, first of all, I think you have it in your paper, but the delay, I mean the total ischemic time, would you mind to address in both groups? There was no statistically different, but would you mind to tell us to begin with, how was that time delay?
The total ischemic time?
Yeah, because as we know, this is one of the drivers of infarct size. So
the inclusion criteria of the trial was less than 12 hours of presentation with ischemic time, so the symptom onset. In this trial, we had about 2.4 hours, so that was the mean delay, mean total ischemic time, and we did not have any statistical significance between the groups. That's the only important point that I can think of in regards to the total ischemia time. But there were patients came up after 6 hours as well, up to 12 hours.
Great. Any other finding as far as ST resolution, anything else that you have seen with the use of this combination? Because it's a very benign combination to use. It's like, why not to use it? We use it for effect of contrast media, so would you say that this would be no contraindications, to my knowledge? And so how would you further explain on this?
I don't quite understand the question. Sorry.
No, what I mean is this is a very benign medication. I wonder if you have seen any ST resolution difference in both groups.
We did not explore the ECG parameters, unfortunately, in this trial at this stage. We have the data. We would be investigating further into this ST segment resolution later on. But is that enough?
Maybe you have.
I would suggest Professor Beltrami to.
Perhaps I can help. So I'm John Beltrami, I'm the principal investigator for this investigation.
Can you move to the microphone, please?
Oh.
Yeah, just move closer to the microphone.
Okay. Okay. Sorry, I'm John Beltrami. I'm the principal investigator for this study. So in answer to your question, it is a fairly safe drug to use. I mean, we actually, in our hospital, have been routinely using it for the past 20 years. But I guess we still want to show that it's efficacious. What we've shown is that there's a reduction in infarct size. I guess one of the pending questions will be, what about the clinical endpoints? And I think then it would be could be more broadly used. And the ST segment data, we've certainly collected the ECGs. Initially, we had the concept of having continuous ST monitoring, but this became difficult in the acute coronary syndrome setting to do that. So we've just got standard ECGs, which we're analysing at the moment.
I'm sure there are some questions.
Hi, Shelley Wood with TCTMD. Are you saying that you're using this drug, you inject this in the same way that you would to prevent contrast nephropathy, or you're injecting it differently?
It is injected differently.
So perhaps if I could help out here. So we use it as an infusion. In some of the contrast-induced nephropathy, it's used as an oral medication, but we use it as an infusion. And one of the key differences is we initiated this in the emergency department when the patients arrived with ST segment elevation. And then continued it on for 48 hours, as you heard in the protocol. So that may be different to what some of the other people have used. The other thing that I think is important is it's used in combination with intravenous nitrates. And I think that the potentiating effect with between the NAC and the nitrates is also important.
Okay, and does it add any time to the procedure?
No, because this is in the emergency department. As the patient arrives, they started up the infusion, the GTN infusion, the N-acetylcysteine infusion. So really there's no delay. As you can see, we haven't presented our daughter balloon time was no different between the two treatments. And again, in the hospitals that were involved with this, it's used probably more common and not an unfamiliar medication to use.
Okay, last one. On the basis of these results, are you using this routinely, or do you need more study?
As I said, we are using it routinely because we've done several other clinical studies where we see that believe there's benefit with N-acetylcysteine. I think we have to put it in context that this is a small study. We've called it a pilot study. It's looking at a surrogate endpoint, and I guess the key thing we need to do is look at clinical endpoints in terms of to assess its benefit before I guess we'll start seeing it appearing in routine guidelines.
Thank you.
There are a couple of questions. One more at the right.
Hi, Sue Hughes from Medscape. There have been several other compounds that have shown similar results, I believe, but they haven't translated into clinical endpoints. Do you think this could be different, and why?
Excellent question. So particularly I think what you're referring to is there was a cyclosporin study done in about 2008. Similar to this sort of study, same number of patients, same sort of result in terms of reduction in infarct size. And then when they progressed on to the larger study that was just published last year, looking at the clinical endpoints, it failed to translate to those clinical endpoints. But I think there's a few differences. One of the interesting things is that the cyclosporin study, the initial phase 2 pilot study, did use intravenous nitrates. Also, the cyclosporin was given at the time of angiography, whereas in our study, patients received the drug when they arrived in the emergency department, so certainly had time for loading. And I think as Thashi has shown, it not only addresses reperfusion injury, but also improved reperfusion. And I think it's those two facts that perhaps why we've seen the positive result. And the key thing, I think, is we need to now progress on to a clinical outcome study.
Any other questions or
Yes.
there is a comment?
Excuse me, Peggy Peck with MedPage Today. I am curious, though, as to how you decide. You've said several times now that you're using it routinely. So I want to know how you came to the decision to use it routinely, and yet you're hesitant about making a suggestion that this be be used beyond the routine use in your own setting. So can you just explain to me? Why did you just start doing this, and why did you continue to do it without it being a guideline indication?
Okay. Again, a good question. So I guess when I put my scientific hat on and interpreting this scientifically, as I said, I think before we can use this widespread, we need sort of a clinical endpoint study. In terms of our own hospital, I mean, there's data going back 20 years ago showing from colleagues within our department demonstrating that in patients presenting with unstable angina, the use of nitrates and NAC reduces the risk of infarction. Again, small studies that were done many years ago. So I guess this has tended to bias our practice. We've also done an earlier study where we looked at the use of N-acetylcysteine in thrombolysis therapy, and again looking at on that occasion it was surrogate markers because it was looking at oxidative stress. We saw less oxidative stress, so again gave us the background to undertake this study.
Still doing it.
Yeah, I guess it's most hospitals have different practices, and this is one of our particular practices, I guess.
You also said that there is a protective effect of your combination therapy for contrast nephropathy. Did you count contrast nephropathy events in your study cohort, and did you see a significant difference between the study groups?
Yes, we did, and we did not see any difference between the two groups in contrast-induced nephropathy.
Great. If there are no further questions, I think we'll just